Hi learners, it's Molly from Sound Nerds, and this short video is going to be a brief introduction to lung ultrasound for the general sonographer and the general sonography student. We'll take a look at anatomy, physiology, appearance, protocol, and basic pathology. So why should you care about ultrasound? Well, for one, it's really showing up everywhere. Emergency rooms, ICUs, inpatient units, even in ambulances. And COVID-19 really made lung ultrasound even more visible. But it is here to stay, and as a sonographer, your skills in probe control and pattern recognition give you a head start. So understanding what you're looking at and how it compares to other modalities like X-ray, CT also help you kind of connect the dots when you hear get a lung scan or see a patient headed for imaging. It's not just a new skill, it is one that builds on what you already do well. Lung ultrasound is a valuable point of care tool for evaluating respiratory conditions. Lung ultrasound is one of the most powerful tools a general sonographer can add to their skill set. It's fast, portable, and can be used nearly anywhere, again from the ER to the ICU to rural clinics, which is why it's really picked up a lot of speed in the POCUS or point of care ultrasound exams that physicians are providing at the bedside. When a patient comes in short of breath, they can quickly scan and start narrowing down the differential before a chest X-ray is even ordered. It's especially helpful in critically ill patients or during pandemics like COVID-19. The thoracic cavity is superior to the diaphragm and contains the heart and lungs. So talking anatomy, the lungs are housed in the thoracic cavity, which is above the diaphragm. That diaphragm is a crucial landmark because it's the lower limit of what we can see on lung ultrasound. When we scan the chest wall, the first key structure we aim to identify is that pleural line, and this is where the visceral and parietal pleural meet. Getting a good view of that line really helps us spot normal lung motion and any signs of pathology. So looking at our diagram here, we have the thorax above the diaphragm. Remember, the diaphragm is a big muscle, helps us breathe. When we inhale, the diaphragm comes down into the abdominal cavity, creating negative pressure, allowing air to come into the lungs. And then when we exhale, the diaphragm kind of springs back up, makes the thoracic cavity smaller, and then pushes the air out of the lungs. The lungs sit on the right and the left side of the heart with an extension kind of behind the diaphragm on the posterior side. The pleural space is a key focus in lung ultrasound because fluid often collects here. The pleural space is the thin gap between the visceral pleura, which covers the lungs, and the parietal pleura, which lines the chest wall. In healthy patients, only a small amount of lubricating fluid exists in here to reduce friction. However, this is a common site where fluid can abnormally accumulate, what we call a pleural effusion. So recognizing this space and identifying changes in it are central to interpreting lung ultrasound, especially in trauma or heart failure patients. So again, looking at our diagram, we're kind of looking at the lung itself. And if we'll look at this little zoomed in part here, we have the parietal pleura. Again, that's going to be lining the chest wall directly in with those muscles and right along the ribs here. And then we have the visceral pleura, which is the lining of the organ itself or the viscera. The space in between these should have very minimal fluid in there mostly so the lung can expand and contract and slide against the chest wall. Each lung is divided into lobes. There's 3 on the right and 2 on the left. The right lung, having 3 lobes, has the superior, middle, and inferior lobe, or the upper, middle, and lower. And then the left side has 2. It has an upper and lower, or superior, inferior. The lungs are separated by major fissures. And we can see that in the diagram here. Sometimes these do show up on ultrasound, but not always. It's important to recognize that it could be a fissure if you're seeing possible artifact or abnormalities in your ultrasound. As far as physiology, gas exchange happens in the alveoli. The alveoli are the functional units of the lung. They're little balloon sacs where gas exchange takes place. Oxygen diffuses into the bloodstream and carbon dioxide leaves. They might be tiny, but there are millions of them, and they're filled with air, which makes them poor conductors of ultrasound, and that's why normal lungs are mostly artifact. But when something goes wrong, like fluid fills the alveoli in pulmonary edema, or they collapse in atelectasis, the ultrasound image changes, and suddenly we start to see patterns like B-lines or even tissue like consolidation. So understanding what's happening in the microscopic level helps us to interpret the larger scale patterns that we'll see with the probe. So air is the enemy of ultrasound, but artifacts are our friend when it comes to lung ultrasound. Air scatters ultrasound waves, which prevents us really from visualizing most lung tissue directly. However, this physical limitation is exactly what gives rise to reliable and diagnostic artifacts. We're going to look for things like A lines and B lines, two of the most important artifacts seen with lung ultrasound. Pathology modifies how these artifacts appear, so rather than fighting air, we use it as a diagnostic advantage by learning to interpret what it leaves behind. Before we get into the artifacts, I do want to cover quickly some of the more common pathologies that can be identified by lung ultrasound. Number one, we've got subcutaneous emphysema. This is going to be air trapped within the subcutaneous tissue, often after trauma or chest tube placement. We can also identify pneumonia, a lot of times as a response to COVID-19. So pneumonia itself is just an infection of the lung parenchyma, where COVID-19 is going to be a viral pneumonia caused by SARS-CoV-2 with a predilection for peripheral subpleural involvement. COPD is a chronic airflow limitation from emphysema or chronic bronchitis. We often see that the lungs are hyperinflated with this. We can also see lung consolidation. This is where the alveoli fill with fluid, pus, blood, or cells. We can see pleural effusions, which is a fluid accumulation between the visceral and parietal pleura. Pneumothorax is going to be air in that pleural space causing lung collapse. We can also see interstitial lung disease, which is a group of disorders with fibrotic or inflammation of the interstitial spaces. Then we can also see pulmonary edema, which is fluid accumulation in the lung interstitium and the alveoli, typically due to heart failure. Each of these really does have a characteristic sonographic appearance. For example, consolidation appears kind of tissue-like. Pneumothorax is going to show that absent lung sliding sign, and A lines are going to be gone. Pulmonary edema, and a lot of these are actually going to show B lines in multiple areas. So recognizing these patterns kind of allows us to triage patients quickly and then kind of guide their next steps in care. So as far as the protocol goes, make sure that you use a curvilinear and a linear probe on the patient, and you're going to have them either supine or sitting. The curvilinear probe really is going to show that deeper pathology, where the linear is going to be a little bit more ideal for superficial and identifying the pleural line, especially in pneumothorax. When you place the probe on the patient, make sure that you place the probe in the longitudinal plane. This is more the default and preferred view. You can also go transverse and in between rib spaces. This will give you a little bit more of a broader view, but is not the standard. Can be helpful if you have to work around lines or bandages. So looking at our example here on the side, we've got the patient with their arm raised. We're coming in more from the lateral portion on the superior border, and we've got the probe in this longitudinal view. When we are longitudinal, we overlap the ribs. So then we tend to see more ribs in our image, and then we see the lung tissue in spaces below. This is going to be more of our default view in identifying those artifacts left behind. On the bottom here, we can see that the sonographer has rotated the probe transversely and is now kind of situated in the rib space, so we no longer see the ribs and can get a much broader view of the anatomy. We do still see some pathologies along with this, but it is not the default view. When you're choosing your windows, make sure to use the best window to see each of the lobes. The anterior window, which we can see here, is going to be best for looking at the superior lobes of the right and left lung. The posterior window, which we can see here, is going to be better for the inferior lobe of the right and left lung. And then the lateral window, while it does give us viewpoints of all of the lobes, is best used for that right middle lobe. There's been multiple protocols that have been explored with lung ultrasound. The one illustrated here is from lung ultrasound as a first-line test in the evaluation of post-COVID-19 pulmonary sequelae. And this is a 12-point ultrasound, basically 6 windows on each side to take a look at the superior and inferior portion of each of the lungs. So they choose a posterior approach and do the inferior and superior part of it, a more lateral approach looking at inferior and superior, and then an anterior approach looking at the inferior and superior. In this specific case, they do give points if they see normal or abnormal artifacts. By dividing the chest into 6 zones and doing it in a very particular order keeps the protocol standardized and efficient for reading and reproducing. So let's go ahead and take a look at some normal artifact signs that we see with ultrasound. Again, these are normal, and then we'll follow up with abnormal. So the bat wing sign shows a normal pleural lining between two ribs. Here we are looking at the anterior chest wall. The probe has been placed in the longitudinal plane, so we have two ribs in our window here. Below that then is this first bright white line. This is the pleural lining. This is that space that would have fluid in it if it was abnormal. However, it is thin and it is normal. So this actually shows us the bat wing sign. You can see highlighted on this picture with the ribs representing the wings and the pleural line in between representing the body of the bat. And then we have shadow coming off the ribs, which again helps us to identify that those are indeed ribs. In the abnormal view of this, if there was a lot of air in the pleural space here, that would be a subcutaneous emphysema, and we would lose visualization of the shadowing. We would lose visualization of the pleural line. A lines are horizontal reverberation artifacts that also suggest normal aeration. So A lines are going to be equidistant, very bright repeating lines that appear deep to the pleural line. So in our image here, this is the pleural line here, and then we can see that there are these reverberations, throwback to physics, equidistant lines that go deep into the image. They're going to result from the ultrasound beam bouncing between the pleura and the probe. So A lines means that there's air, so you'll see them in healthy lungs, or kind of as a side note, hyperinflated lungs like we see with COPD. You won't see A lines in areas of fluid or consolidation. So think of A lines as more of the default, the normal, the healthy. A lines means air is in the lungs like it should be. So here's a little video from Radiopedia, and you can see the A lines move as the patient breathes. Again, that is normal. We expect to see the lungs moving back and forth with inhalation and exhalation, and those A lines going all the way through. Another sign of normal lungs is the curtain sign. The curtain sign is when the lungs inflate. They're going to move downward like a curtain and obscure the liver or spleen. So here is that example. We're at the level of the liver. Normally we would see the superior border of the liver. The diaphragm would be coming across here as well. But as the patient inhales, the lungs expand and drape kind of over the liver. And because they're filled with air, they're attenuating the sound, causing a curtain to come over and obscure. If we don't see this curtain sign, or if we see lung kind of stuck up a little bit higher, or there's anechoic fluid up there, all of that kind of points to a pleural effusion. Another normal sign is lung sliding, and this is seen when the pleural line moves under the chest wall. So in this GIF from ultrasoundidiots.com, we can see a rib here and a rib here. And if we watch this, this is the thin normal pleural line, and we can see it almost kind of shimmering and sliding as the patient breathes in and out. This is going to confirm that the two pleural surfaces are in contact. If we don't see this sign, that's going to be an indicator of pneumothorax. But remember, it can also be absence in the setting of pleural adhesions or apnea, so we do have to be careful of the context. We can use M mode to show the Seashore sign, again a normal sign showing that pleural sliding. So we saw this image before where we had the two ribs and we could see the pleural line in between. M mode is put in between and the patient's allowed to breathe. What we see then is something called the Seashore sign. We see the C out here as moving lines that also represent kind of the muscles of the chest moving with breathing. And then we see the pleural line, which is kind of the shore, and then we see more of that lung tissue moving back and forth as the patient breathes. So this is showing quite a bit of side-to-side movement of the lung tissue, which is normal. Getting into abnormal now. These are the things that if we see them, we might think something's going on. We need to look deeper into the patient's history or symptoms to kind of identify how what we are seeing is abnormal and how it relates to their diagnosis. So B lines are going to be vertical hyperechoic artifacts that usually indicate some sort of interstitial disease. So here is a rib and here's another rib. So you can see usually when we're in that longitudinal view, we are overlapping at least two ribs. And then we look for the pleural, and we can see that here, that pleural line. But instead of seeing A lines, those artifacts, the air artifacts reverberating down, what we're seeing instead are B lines. And B lines are going to be these vertical echogenic lines extending from the pleura. It's not abnormal to see maybe one or two in certain areas of the lung, but if we see any more than three, that is considered a positive finding for lung pathology. Oftentimes we're going to see them appear in cases of pulmonary edema, interstitial fibrosis, pneumonia, COVID-19, but whenever they are there, there's usually some sort of disruption to how the lung is functioning. So again, B lines really are typically only present in abnormal circumstances when something is abnormal with the lung. Sometimes we'll see it on elderly patients. Sometimes we'll see it in certain parts of like the posterior lung. But typically if you see them, especially anywhere in that anterior middle area, something is abnormal. In fact, this patient has a little bit of lung consolidation going on. They have a pleural effusion, which we can see here. But at the beginning of the clip, right in between the ribs here, you can see those B lines coming down. And you see also that we're missing those A lines. So A lines and B lines don't typically present together. It's the missing A lines and the presence of B lines tells us something's going on with the lung. Usually there's a little bit of extra fluid within the tissue itself. So again, it's normal to see that pleural lining sliding along the chest wall. It is abnormal when we have an absence of lung sliding, and that can suggest a pneumothorax or a pleural adhesion. So if we lose the sliding and we lose A lines, we need to suspect a pneumothorax. Again, M mode can be very helpful in diagnosing this. An M mode is used, again, between two rib spaces where we would expect to see pleural line and then see into the lung tissue itself. M mode goes on, and what we see is no motion. This is known as the barcode or the stratosphere sign, where we see no motion and it's just horizontal lines all the way through. That means that the lung is not moving appropriately, therefore not moving air as it should. Consolidation of the lung appears as tissue-like echogenicity known as the hepatization sign. This means that the lung looks a lot like the liver on ultrasound, kind of solid and homogeneous. You may also see air bronchiograms. These are going to be hyperechoic spots or lines representing air-filled bronchi, which are hyperechoic spots or lines representing air-filled bronchi within the fluid-filled lung. This is a classic sign for pneumonia, but also shows up in atelectasis and lung infarcts. Make sure to use appropriate depth and probe choice so we can see all the way through this dense, non-aerated lung. So looking at our example, this is abnormal. If there was normal air in a normal lung, we would not be able to see this. This would be nothing but artifact because of attenuation and the way that air scatters ultrasound. Instead, though, the alveoli are filled with fluid or pus or something that's causing it to kind of all consolidate together, and now we actually can see the parenchyma of the lung. And this is called hepatization because you can see it looks a lot like the liver parenchyma just south of the diaphragm here. So this is an abnormal appearance. This is consolidated lung. As we look through it, we do see some brighter echogenic areas within the lung tissue itself. This is again is known as air bronchograms. We are seeing air in the bronchi of the lung. The spine sign is also going to suggest an abnormality is present, specifically a larger pleural effusion. Now, normally when we're scanning the lung, diaphragm, liver area, we're going to see the liver, we'll see the diaphragm come across as a bright echogenic structure, and then we do see some vertebrae in the far posterior field. Superior to the diaphragm, again in the normal chest, this is all going to be artifact. It might be mere artifact from the liver, kind of reflecting across the diaphragm, or it'll just be artifact from the lung itself, causing, reverberations or scattering of the ultrasound. But with that, then we usually don't have enough ultrasound energy to continue seeing the spine in that posterior field. So it looks kind of like the spine just abruptly ends. When it's abnormal, because there's fluid in here, That fluid acts as a great window to continue seeing into the posterior body. That fluid, which is a pleural effusion, then allows us to see the spine as it continues through the thoracic cavity. So here's another example of that. Again, pleural effusions usually appear as anechoic or complex fluid superior to the diaphragm. And again, we can see the diaphragm coming across here. Normally, the spine just stops right at that part because this is all artifact up here from the lungs being filled with air. But we can see that there's fluid here, we have some fluid here, and so what we can see then is the thoracic vertebrae continuing past the diaphragm. This is abnormal, so this is known as the spine sign. So you can see that lung ultrasound can help identify pleural effusions and parenchymal abnormalities. So we are able to detect pneumothorax, pleural effusion, consolidation, and interstitial syndromes. Ultrasound can be slightly more sensitive than a chest x-ray in some acute settings, and it's actually really helpful for guiding procedures like a thoracentesis. Here in this example, we have a patient receiving a thoracentesis. This is going to be where a needle is introduced into the thorax and the fluid from the pleural space is withdrawn. So pleural effusions are probably one of the ways that ultrasound is used the most, not only for identifying them, but for also guiding the needle in. This image is actually from Blue Phantom. This is a phantom in which people can practice withdrawing fluid from the pleural space, but we can see the pleural effusion or the fluid here. This is representing a consolidated lung area, and then we can watch the needle come in with ultrasound past the pleura and then into that fluid. So pleural effusions do often appear as anechoic fluid if they are simple fluid collections. They usually are more in the dependent portion of the chest, so that a lot of times we'll have the patient sit up so that fluid kind of falls to the more dependent inferior portion of the thoracic cavity. And it's not uncommon to see septations or debris in that pleural effusion, especially in the setting of infections. We also mentioned earlier that lung ultrasound was actually really helpful in assessing COVID-19 patients for pneumonia. So lung ultrasound is helpful for assessing that. Findings often included irregular pleural lines, patchy B lines, subpleural consolidations, and spared areas in between. So the disease typically affected more the posterior and peripheral lungs, areas that ultrasound actually visualizes pretty well. They were using serial exams then to help monitor progression or improvement, especially in settings where CT or repeated x-rays are impractical or unsafe. So a lot of times these patients were hooked up to ventilators. It would be a lot of effort to move those patients down to CT every time that they wanted to take a look at the lungs. And the x-rays only could show so much too on like the portable chest x-rays. And so they really started using ultrasound as a way to kind of monitor the progression of the lung disease with COVID-19 patients, especially those that were in the ICU and not mobile to come down to imaging. So just to kind of recap some of the things that we saw already as far as artifacts, but some things specific to COVID-19. Again, we've got these B lines here. Remember, anytime you see B lines, they're going to usually erase the A lines, and that is an abnormal finding. So we've got more than 3 in this view here. That is abnormal. We're also seeing some consolidated B lines. So instead of seeing these individual ones, we see that they kind of get all scrunched together. It's also known as a waterfall. But we see then too that the pleural line is pretty abnormal through here as well. It's a little bit thicker. Again, we're seeing some areas of consolidation here, and then we've got B lines coming off of it. And then this is that bronchogram that we were talking about earlier, where we can see echogenic lines in a fluid-filled lung tissue. And so we can just see kind of the outline of the bronchioli with the air inside of them. So we really did see lung ultrasound improving both the speed and accuracy of bedside decision making, which is why a lot of doctors and internists really took to learning POCUS, especially bedside ultrasound and looking at the lungs. It was able to help them make better diagnoses. It also helped them to avoid delays associated with waiting for X-ray or CT, especially in unstable patients. And it really helped to enable that dynamic monitoring over time. So you can watch for the B lines to lessen, maybe the A lines start to come back. You can monitor the fluid collection that's in the pleural space. You can see if the consolidation is improving. So there's lots of things that they could do with that bedside ultrasound. But remember that ultrasound usually is used to complement, not replace, a chest x-ray or CT, especially when appropriate. Remember, a lot of patients are actually really going to benefit from the use of an x-ray or a CT to really get a full global view of the thorax and its contents. So while ultrasound is really great for pleural or subpleural abnormalities, it really can miss kind of more central lesions to the lungs or masses or just even really subtle findings. So it's more of an extension of the physical exam, kind of getting a sneak peek as to what's going on without subjecting the patient to more ionizing radiation, and it's just, again, used as part of the clinical puzzle. So just to recap, lung ultrasound is a fast, portable tool to detect major pulmonary pathology. The artifacts are what is going to hold the diagnostic value. From pneumothorax to pulmonary edema, it offers bedside answers using diagnostic artifacts. Remember those A lines, the B lines, we're looking for pleural sliding, and more. It's safe, it's repeatable, and essential in modern practice. So as a sonographer, these pattern recognition skills are already in your toolbox. You're just applying them to a new landscape.